I start, well, on antagonists, on types of antagonism, I said that competition antagonism, you can do what? You can surmount competition antagonism by increasing the dose of the agonist. What is affected is what? The potency of the drug. EC50 will shift to the right. Maximum response, the dose at which we shift to the right. For non-competitive antagonism or the inverse antagonism, I said that in the presence of the antagonist, you would not surmount, the agonist will not surmount the antagonism. So what is affected is what? Is the efficacy of the drug. Efficacy is reduced. That is the implication. For allosteric antagonists, I said that there is always some receptors are what we call allosteric site. Just like some enzymes always have what we call allosteric site. Allosteric site will be a different site, a different binding site from the main binding site. So what happens is that once the agonist binds to the main binding site and the antagonist binds to the allosteric site, the allosteric site, the allosteric site now, with the antagonist will now modify the activity of the agonist. It's more like it short circuits and breaks off the effect you get with the agonist. That's why it's what we call a stand allosteric antagonism. The first one is a function, what we call functional antagonism. This is seen in, a lot of it is seen in the clinic. What happened? Somebody that has, let's say, anaphylactic shock, for example, anaphylactic shock, histamine, a lot of histamine is like, when I mean that, I mean this reaction, allergic reaction, that is already threatening, life-threatening. So histamine is a lot of histamine H1 receptor. There is a lot of histamine binding to H1 receptor. That's why you have what? That asthmatic attack. What is the first thing they give these people in the hospital? Maybe when you see them in AR or in those vehicles that they take. One of the first things they give them is what? Adrenaline. Which I'm going to explain why. Right? Histamine H1 in that reaction will cause what we call bronchoconstriction. Those people in the experience anaphylactic shock will begin to grasp for breath. They can't breathe well. So there's bronchoconstriction that happens because of what? Histamine binding to H1 receptor. So histamine itself is what? An agonist in a way. Do you get it now? So what they used to do is they give them adrenaline. Sure, adrenaline. Because adrenaline can bind to alpha 1, alpha 2, beta 1 or beta 2 receptor. By binding to its own beta 2 receptor, adrenaline can cause vasodilation, bronchodilation at beta 2 receptor, which will contradict the effect of what? Histamine at histamine H1 receptor. You get that? So in functional antagonism, you're saying that one ligand in a way nullifies the effects of another ligand, not at the binding site, but in the body, or in solution in the body. So that's what we call it functional antagonism or physiological antagonism. So the effect of one ligand kind of cancels out the physiological effect produced by the other ligand. That is an example of what? A functional antagonism. Now, having said that, I want to run over this quickly. Quantum dose response. In graded dose response, so that you can increase or decrease response. Just like you can have Emax or EC50. But in quantum dose response, here, you are measuring a quality of response. So if you talk of either all or nothing response. This also happens with nerves to some extent. That it's like when I say I want 50% response. If I say I want 50% response, so the drug I'm given, now the drug can produce 50% and above, all. Or it produces less than 50. Yes, it showed a response, but because it didn't reach the threshold that I want, this is what? Nothing. So this is what? A quantum dose response. That a drug or a ligand can either produce what? It's either producing a full response or it's not producing any response. Based on how you're measuring that, it's what? All or nothing, quantum. Then it gets to the threshold or it doesn't. It is the relationship between the dose of the drug and the proportion of the population of patients that respond to it. So you are looking at a large pool of people to determine this quantum dose response. Not just in one person. So you can use it to get some some results. That is that. So more like all or nothing qualitative response. Now, I mentioned this before, therapeutic index. That therapeutic index tells us how safe a drug is. So what is the formula? The formula is what? LD50, leader dose in 50% of the population, or sometimes people say toxic dose. So whether you are saying LD50 or TD50, leader dose or toxic dose in 50% of the population over the effective dose in 50% of the population. So a safe drug will have a wide therapeutic index. So a drug can be efficacious, can have efficacy and not be safe, like warfarin. A drug can be effective and have a wide TI. It means that what? There is room to make mistake, and there will not be problem with overdosing or a problem of what? Poisoning. Example of drugs like that are penicillins. So drugs that are safe will have a high therapeutic index. Drugs that are not safe, we have what? A low therapeutic index. So therapeutic index is different from what? Effectiveness of the drug. Therapeutic index only talks about what? How safe, how clinically safe a drug is, and how it can be used in therapy. And if they will class as drugs that, so most OTCs should be relatively safe. Some drugs that you not find on the counter must be drugs that will have what? Low therapeutic index. So if a drug is not safe, it's not be over the counter where anybody can just go and buy. Somebody can go and buy. So these are just one of the major concepts we're talking about, what? Pharmacokinetics or pharmacodynamics, and this is where we call it a wrap. So I will advise you, please go online, watch the videos, like, comment.